All right, so yeah, thank you everybody for coming. We're here with Dr. Lora Liu, who's based out of New York. So a lot of people on this call are here, so this is even better. Um, and actually, we hit the next slide.
All
The
right, give me
next,
1 second. It's not coming up. Sorry, guys.
maybe just hit the arrow on the keyboard.
Let's just do that. I can see okay, there we go. It's up now. My
All right.
apologies.
All right, so here's a little intro to Dr. Liu, but I'll let her speak herself. So Dr. Liu, if you want to introduce yourself and just let us know how you got into endometriosis surgery specifically.
Yeah, absolutely. Thank you so much for having me here tonight, Nicole. This is very exciting, and I love talking about endometriosis. So thanks for providing this platform. So I'm Dr. Liu. I am an OBGYN, and then I did a fellowship in minimally invasive GYN surgery because I didn't like delivering babies. I found it very, very stressful. And I was like, there's no way I can do this for the rest of my life. Even though it was very exciting, but after residency, I'm like, I can't do this. It's too stressful for me. So I'm like, let me just focus on surgery. And my father was also a GYN surgeon. And so I really did enjoy not doing, but I enjoyed going to the operating room with him when I was little and watching him do surgery. I thought it was very, very cool. So that kind of sparked my interest. And so after residency, I did a fellowship. And then after that, I just kind of got into endometriosis and just really wanted to focus on that, just because it's a crazy disease. And I think a lot of I love a challenge, and endometriosis surgery is you never know what you're going to get. Like you get a negative MRI and you're like, oh, this is like going to be not a bad case. It's going to be stage 1. And you get in there and you're like, oh my goodness, like this is insane how crazy this disease is. And it can grow on every single organ. It's not just a GYN issue. And so that's what I found that I really enjoy doing. Every single case is a challenge. And I really feel like it makes a huge difference. I feel like the surgery can it can help so much in so many people. And I also like how it is a multi-organ disease. I actually like it because then that means I get to work with other people in the OR. And it's always nice to have friends in the OR. And so I usually work with either a neurologist or a general surgeon. Sometimes there's a plastic surgeon that comes in for like umbilical endometriosis to repair the belly button. Um, there's been a couple of cases where they've done a like a abdominoplasty or liposuction in conjunction with endosurgery, if the patient wants that. And so we really try to make it all about the patient and really do what's best for the patient. And then let's see, vascular surgeon, I had him in yesterday, as well as a cardiothoracic sometimes if needed. So it's crazy how much this disease can affect the whole body. It's not just about the reproductive organs. And I think that's enough about me. I can talk forever though, but I think we have more interesting things to discuss than this. So we can go to the next slide.
Thank you. So yes, first we're going to talk about the hormonal management with endometriosis, especially post-surgery, and then debunk some myths and really get an understanding of Orilissa and the Lupron discussion. And then, like Dr. Liu mentioned, the systemic impact, how endometriosis is not just about the reproductive area,
She's in the thing.
all other organs. And then the surgical decision making. How do you find the right doctor for you? How do you find a professional?
Well, hold on a second. I'm on I joined from my cell.
Cheryl, can you mute yourself?
Hi, Cheryl. All right, sounds good. Let's go to the next slide. Perfect. Hormonal management. Okay, so why is it often prescribed as first-line treatment? I think birth control pills definitely has its place. Hormonal management, when I say hormonal, oh my gosh, hormonal management, I usually am referring to regular birth control pills like low estrogen that has a combination estrogen progesterone component to it. There's also progesterone only pills, norethindrone. I think Slind is, Slind is now becoming pretty popular, or the mini pill, where it just has progesterone only. And then let's see, IUD, like the Mirena IUD, progesterone only IUD is also hormonal management. The Depo-Provera shot, the implant, the progesterone only implant. So when I talk about like hormonal management, that's kind of what I'm referring to. And why is it often prescribed as first-line treatment? I like I said, I don't think it's a bad thing. I think it has its place. So for instance, if I think a lot of my patients, they're like, I remember the first time I had my period is horrible. I was 12. I was in the bathroom, and then, around 14, I got put on birth control pills because, I was missing school. And I think in that regards, or when a mom reaches out to me and asks, my teenager is really struggling with her periods, what should I do? I usually say, try birth control pills, see if that works. If it does, and I always want to make it clear that, hey, it's something that you can try. Let's see if it works. If it gives back quality of life for the patient, great, but if it doesn't, don't just keep on trying this drug, that drug, this brand, this formulation. Let's not keep on doing that, because that's how it just really delays diagnosis. But I think as a first-line management, it's not a bad thing. What it can and cannot do for endometriosis, what it can do is it can help your symptoms. A lot of my patients are like, yeah, I went on the birth control pill at 14 and everything was fine. Everything was great. I stayed on through college. I stayed on until I got married. Then I got off of it. When I got married, we started to try to have a kid, and I just remember that my periods just became awful. Or I got off of it to try to get pregnant and couldn't. So it can manage the symptoms, and it can do it very effectively. But what it doesn't do is it doesn't treat the disease. It doesn't make it go away. It just makes everything so it just suppresses the symptoms. For some patients, it doesn't do anything at all except give you terrible side effects. I was talking to a patient today, and she was like, yeah, when I'm on birth control, I become homicidal. Like I had to get off of it, or I was literally going to kill someone. I was like, yeah, so that's not the right fit. We should not do birth control pills for you. And she's like, and it didn't help anyway. So, so for some people, it doesn't help, but for some people it does. And for the people that it does, I think it's fine. I think it's a fine management strategy. What I don't agree with is for patients to be told that that's really only their only option is, if they go to their OBGYN, it's like, hey, this is not working, I'm still in pain. And then they get bounced around to 47 different types of formulations. Well, let's try this type, let's try this type, let's try this type. And, 5 years later, it's still just not working for them. I just don't think I don't agree with that kind of management. But like I said, if it manages your symptoms and your quality of life is good, I have no problem with it. So, but it can, to the next bullet point, it can mask the progression, because you are feeling pretty good. You don't really have a lot of symptoms, but like I said, that fire is still burning. It's not out. It's still smoldering. And so when you come off of the birth control pills, a lot of times it's just like nothing ever changed. And it could even become worse. And that's another problem, is because it is a Band-Aid. It does mask or manage the symptoms to the point that you may or may not forget about it, and until you come off. And then when you come off of it, I don't want to say that it's too late, but the disease certainly hasn't gone away. It hasn't resolved anything. So you're back to square one, if maybe not even further down the field. Long-term implications of management versus treatment. So again, birth control pills, hormonal management, it's management, it's not treatment. And it really makes me upset when it's touted as being a treatment, because when I hear treatment, I feel like, in my mind, when I hear treatment, it means that you've actually done something about the disease. You've done something about the root cause of the disease. You haven't just put a damper on things. You've actually put the fire out. You've dumped at whatever. I'm not a fire person. I don't know why I'm using this analogy, but you've literally dug the weed up by its roots. You've taken it out by its roots. And that's what I think about like treatment. Whereas management is just more like mowing the grass. You're just keep on cutting the grass, or you keep on cutting down the weed, but you never really take it out by the root. Treatment for endometriosis is excision. Just like with those weeds, you gotta remove it. You gotta take it out by the root.
And if you want to go to the next slide, because then this leads us into the discussion with Orilissa and Lupron. And if you go on Google or different doctors, or even to social media, there's like such a far extent of people that are for it or not for it. So we can get some clarification on these two.
Yeah, so Orilissa and Lupron. So Lupron is a GnRH agonist, and GnRH stands for gonadotropin releasing hormone, and that is released in the hypothalamus. And what it does is that hormone stimulates your hormones basically. If you're a male, that the GnRH stimulates the LH and FSH, which stimulates your testicles or your testes to produce testosterone. In the ovaries, it stimulates your ovaries to produce estrogen. Lupron actually was created to treat prostate cancer, because for patients with prostate cancer, you want your testosterone to be 0. You literally want to you don't want to have testosterone if you have prostate cancer. So that's what it was originally designed for. And it really only didn't get approved for endometriosis treatment or management by the FDA. I mean, it's only approved by the FDA for limited treatment. You can only do it for 6 months. Just because what it does is just like it does in men, it stops the production of testosterone. In women, it stops the production of estrogen, which basically it means you go into menopause. So we're using these medications that are really designed for prostate cancer on women, on 25-year-old women, and we're putting them into menopause. And it's interesting, and I'm sorry I keep on talking about men, but only I mean, it's a drug designed for men, right? And we're using it on women for completely different indications. And actually in men, even after 6 months of use of Lupron, even after they stopped it, 30 to 40% of them still had persistent symptoms. They had side effects, and no one really cares, because it's like a guy, they're 80 years old, they're prostate cancer people. Like, no one cares if there's side effects in an 80-year-old, right? We don't care if your testosterone is 0 if you're an 80-year-old with prostate cancer. But, the same stuff is happening to women who are 25. And even after stopping after 6 months, the side effects can still persist. And I've had so many patients tell me that Lupron literally has ruined their life, even if they're on it for 6 months. And then with the Lupron, if you want to stay on it longer than 6 months, then you have to start doing the add-back therapy. So you have to, in addition to Lupron, then you have to start giving yourself estrogen and progesterone to counteract the side effects, as well as help with the bone density. So I think Lupron is just it's just not a good option for patients with endometriosis. And I find that it's still to this day, it's still getting pushed on patients, young patients, and now these patients are still suffering side effects from it. Orilissa is a little different. It kind of works the same way, but it's not an agonist, it's an antagonist. And so for Lupron, it basically shuts the ovaries down. It turns the lights off. Orilissa just dims the lights. But so there's a lesser side effect profile for Orilissa, but a lot of patients, and again, I'm seeing all the patients who are Orilissa and Lupron have failed. I don't know a lot of people who've ever loved Lupron, but I also have had patients who have had reasonable symptom management with Orilissa. But again, with Orilissa, the side effect profile is still there, and you can only use it for 6 months to 2 years. After that, you can't use it anymore. So that's, I don't know. People ask me about it all the time. I'm like, I don't prescribe it. I don't think it's a good idea. I think the side effect profile is too high, and the long-term effects as well. Patients really still suffer from it. And it's interesting, I actually talked to a patient today. It's interesting that her insurance company, which is this is the first time this happened. She said, actually, my insurance company wouldn't cover Lupron, but it will cover surgery. I said, well, that's interesting. Well, you came to the right place. So I'm wondering if things are starting to change a little bit with the whole Lupron thing. I hope so, because it's been decades of battling against that company. Why they're not a substitute for excision? I mean, just like with birth control pills, it doesn't treat anything. You have to stop after 6 months anyways, or 12 months with add-back therapy. You are miserable, your hair falls out, you're having hot flashes, you're in menopause, you come off of it, you still have the side effects, and your endo is still there. It hasn't gone away. Things haven't gotten better. So you're back at square one. Actually, you're actually behind the game because now you feel like total crap. And a lot of times these side effects are long-term.
And then next slide, Justine, and we can get into the systemic impact, especially around the bowel and IBS misdiagnosis.
Yeah. So endometriosis, like I said, it can affect anywhere in the body. And I think a lot of times when patients go to their OBGYN, and I mean, you guys know better than me, but you talk about GI distress or maybe bladder stuff, and they're like, oh, okay, that's great. Let me send you to a GI doc, where the GI doc is like, oh, great, let's do a colonoscopy on a 23-year-old. And of course, it's negative. And it's like, well, I don't know. I guess it's just IBS. I actually had a patient. She's operated on her last week. She was 21. She had surgery when she was 19 for bowel stuff. She had a laparoscopy where the surgeon was like, yeah, there's maybe, I don't know, your bowel looks a little distended. He sent her to a GI doc. She had a colonoscopy, was prescribed like other, I think, IBS medication. And when we did her surgery last week, she had a huge pocket of endometriosis right over her rectum. And this was 2 years later that she's been bounced back and forth from doctor to doctor and been misdiagnosed. It's really upsetting to me. But I think, so my opinion with IBS, I think it's kind of a junk diagnosis. I think it's just one of those, well, we had a colonoscopy, it's not Crohn's disease, it's not celiac disease. You don't have, like, I don't know, you just have IBS. It's a diagnosis of exclusion. So when people don't know what it is, it's like, well, you have some irritable bowel stuff. So let's just call it irritable bowel syndrome. And a lot of times it's not that. Well, yes, your bowels are irritated, but it's because there's endometriosis, either on the bowel directly or on the nerves that govern the bowel, like the hypogastric nerves. If there's endometriosis on that can cause a lot of bowel dysfunction, urinary dysfunction, and that's why a lot of patients, have to go to the urologist and GI docs a lot because of, and it's actually endometriosis that's just really irritating either the organ itself or the nerves that govern the organ. Why do GIs often miss endometriosis? Well, because if they're doing a colonoscopy, that means that you're putting a camera inside. So the bowel's a tube, and the colonoscopy, the camera goes inside the bowel and it looks from the inside out. Endometriosis is on the outside and it goes in. So you're never going to see superficial bowel endometriosis with a colonoscopy because they're on the wrong side of the tube. And that's why they're like, well, everything looks fine. There's no endometriosis. And so I guess it's just IBS. But that's why it's missed, because they're not looking on the right side of the tube. And like I said, endometriosis is on the outside of the bowel, and it goes in. Different presentation of bowel endo versus IBS, IBD. I think endometriosis, a lot of my patients are like, I have bloating and gas all the time, but especially around the time, my period, I get constipated like 3 days before my period. And then when I start bleeding, then I have the period poops. And then just I have diarrhea and everything just comes out. Or around ovulation, they get constipated. And so with bowel endo, I feel like there's a little bit more of a cyclical manner to it. And then they poop okay for the next week or so, and then it just the cycle starts all over again, and it follows the cycle, the menstrual cycle. IBS, IBD, I don't think there's really much of a cyclical manner to it. Maybe there is a little bit with the hormonal fluctuation, but I think with bowel endo, there's probably more of a cyclical component. Although patients with endometriosis, they have a lot of them have symptoms all the time. It doesn't even matter if you're bleeding, if you're ovulating, it doesn't matter. It's just like I am miserable 100% of my time. So, you can't always depend on cyclical nature of things. Other systemic symptoms: fatigue, inflammation, brain fog. My patients are chronically exhausted. They're just tired. They can literally just drag themselves to work, and they come home and they just literally can't do anything else because they're so exhausted. And I think it's not just, well, first of all, when you're in pain and you're literally fighting pain every single day, that is a lot of work, and that's tiring because you're in pain, your body is fighting it, and then you have to go out and you have to function and be a normal person, be a productive human being, otherwise you're going to get fired. And so that is even more exhausting. And then not to mention that you have so much inflammation. It's not just limited to your pelvis. The disease may be just in your abdomen, your pelvis, but it's like it is widespread. That inflammation can be widespread. And I have patients who tell me, look, I have joint pain. I have like a rash every time I have my period or when I'm ovulating. And it's like, I don't think that there's endometriosis in the joints. I really don't, but it's that inflammation. And because it's abnormal tissue that's not supposed to be there, and it's causing a lot of inflammation, and that the whole body's connected. So you feel it all over the body. And I kind of already talked about the bladder and the nerves, but like I said, endometriosis, a lot of patients have bowel symptoms. Going back to the bowel, a lot of patients have bowel symptoms. It doesn't mean that they necessarily have like a bowel lesion, endometriosis lesion directly on the bowel. Like I said, it can be on those nerves that can cause the bowel to be very irritated. So, and the bowel doesn't know any different, whether it's directly on it or whether it's on the nerves. It's just like, it just knows that something's not right, and it's pissed off, and it's letting you know that.
Are there a lot of, like, for somebody who's struggling, maybe doesn't have like the most painful periods, but is struggling with UTIs, is that something that you could have endo on the bladder and not have painful periods?
You mean like, what do you mean? Like someone who has UTI, like proven UTIs?
Yeah, like chronic UTIs throughout the year, but is fine in terms of their periods.
Yeah, I think that's something that certainly could be the case where it just presents specifically just with UTIs. Generally, if there's actual bacteria and it grows and you're like getting a clean and you're getting a straight urine culture, it's not like you're just peeing into a cup, but you're like actually getting catheterized and it's coming back with positive over what I think 50,000 if it's straight to cath, and colonies, and it's proven bacteria, which I don't know if a lot of people do that, but if that's the case, I would think that maybe it's not necessarily related to endometriosis. I would see that more as some kind of infection. Like I'd lean more towards an infectious disease kind of thing or something else. Maybe there's something wrong with the urinary tract itself. But a lot of patients will be diagnosed with UTIs based on a clean catch and, oh, yeah, there's some bacteria in your urine. Let me just, like at urgent care or at their primary care physician. And yeah, it might grow bacteria, but again, that bacteria is it's not necessarily real bacteria, especially if you didn't actually have a catheter placed in your bladder to drain your bladder. A lot of times it's going to be a contaminant. But hey, if the patient's symptomatic, and there's bacteria in the urine and you're miserable, obviously, yeah, you're going to say, yeah, go ahead and take the antibiotics. Here's the antibiotics because you could have you could have an infection.
Thank you. And then just maybe we can go to the next slide. And now I'll just talk about more of the surgical decision making of when to decide and just run through the different components of surgery.
Yeah, so why does ablation lead to repeat procedures? Well, ablation certainly isn't treatment of endometriosis. What ablation is you're just you see the endometriosis lesion during surgery and you just burn it. You just take, an instrument and you just burn it. And just like how if endometriosis was a weed, you really have to take it out by its root, right? And so ablation, or if you think of an iceberg, when you ablate an endometriosis lesion, you're just really just burning the tip of it. And all the rest of that disease is still there. So that's why a lot of times you might feel better after ablation, maybe for, I don't know, maybe a couple of months or whatever, because I think it does actually decrease a little bit of the inflammation because you have destroyed a little bit of the endometriosis, but you didn't get all of it. You didn't excise all of it. Also, the other thing with ablation is while it may get rid of a little bit of disease or destroy a little bit of disease, when you ablate something, which means burn it. I mean, I don't know if you've ever burned your arm with, on the oven or the curling iron. I mean, that hurts, right? So anytime you burn something, that hurts, and it causes a lot of swelling, inflammation, and then you actually start building a scar. And that in surgical talk, we call that fibrosis. And so not only have you not treated the disease, but now you created more scarring on top of the disease, and that can cause a lot of pain as well. So scar tissue complications, again, that is something that ablation can lead to, is creation of even more scar tissue, and that can cause pain. Why pain returns after ablation? Because it doesn't work, because you didn't get anything out. You just basically, you didn't do anything for the patient, to be honest. Evidence for excision outcomes versus ablation. So excision outcomes are going to give you, so if you have excision surgery, you're going to have better outcomes. First of all, because you've gotten the disease. It's pathologically proven that you've cut the disease out. It's no longer in the patient, right? And you have tissue to prove that. And then not only have you proved it to yourself, but it's been verified by a pathologist, because they look at that tissue under the microscope and they're like, yes, this is 100% endometriosis, or no, this is not endometriosis, it's normal tissue, or this is scar tissue, or God forbid, this is cancer. So we really do know what was removed from the body. Ablation, who knows? You've just completely destroyed it. So that's one thing. And then for excision, there's evidence, with less, like, decreased recurrence rates. So a lot of patients will think that their endometriosis has come back or reoccurred after 2 years. Like, I just had surgery 2 years ago, but the pain is back. My doctor went back in and found more. And a lot of times I'll ask, well, who did your first surgery? Was it your OBGYN who delivered a baby at 4 a.m. and then came in and did your surgery at 7 a.m. and you're seriously the only surgery that they've done for the last 3 months? And a lot of times it's that person. And so the likelihood of someone who's not experienced enough to do excision surgery will also miss disease. And so it's really not recurrent. It's not recurrent disease. It's more of residual or missed disease, or disease that they couldn't get out the first time, or that they didn't know was endometriosis. Because again, endometriosis doesn't look like the textbook Google black dots that everyone thinks is endometriosis. It can be clear, it can be white, it can be yellow, it can be red. And so, when you have it done by, when you have your surgery done by an excision surgeon, who, if they're doing excision, a lot of times they're a little bit more well-trained, because it is technically more difficult than just ablating. And so you will have better outcomes in that respect. I'm sorry, Nicole. I'm kind of like just I see something and then and then I go off in this direction, direction. So just if you need to steer me back, that's fine. I talk a lot though because I have a lot to say. Addressing surgical trauma and anxiety from previous surgeons for those that are scared. Yeah, no, of course. I mean, who wouldn't be traumatized? You've been completely told for 7 to 10 years, and a lot of times longer, that first of all, everything's okay. Nothing's wrong with you. This is completely normal to be in pain during your period and bedridden. It's okay that you're throwing up and that you have heating pad burns on your belly. Yeah, nothing's wrong with you. It's on your head. And then when you finally find someone who's like, yeah, maybe it's endometriosis, and a lot of times it is someone who's not as experienced and maybe just your OBGYN, they do ablation and you feel good for a little bit and then things come back and then you go back to your doctor and they're like, no, it's fine. Here, go on this birth control pill, or worse, yeah, here, go on Lupron because I don't know, we got it all. Like you had a little bit of endometriosis, when in reality you probably had a lot more that was missed. And also, if ablation was used, then there's still disease under the part where the person burned it. So of course you would have. Who wouldn't be traumatized and have anxiety about that? That is very scary. Um, you know, I think I don't know exactly what to say for that, except that I'm sorry. I'm sorry that this is happening, and I know it's happening to millions of women, and millions of women don't even know about the difference between ablation and excision. And they're just fighting to get a diagnosis for why they're debilitated during their periods, or why they have these bowel issues, or why they can't have sex without pain, or why they can't get pregnant. But it is a big deal, and I think, but I don't think it's a bad thing. I don't think it's a bad thing to hesitate and take pause before going in for surgery, because I think it is a big deal, and that you really should ask questions, and you should challenge your doctor, and you should ask all of the scary questions. But at the end of the day, you know, I don't have a crystal ball. Dr. Sechkin doesn't have a crystal ball. No one has a crystal ball. First of all, we don't know for sure whether you have an endometriosis. The only way that we know for sure is to go in there and remove the specimens ourselves, send it to pathology, and we have to wait for the pathologist's confirmation for everyone to know that you have endo. And then also, I tell my patients, I don't know, like, let's say you do have endometriosis. I can't tell you that if you have surgery with me, that you're going to jump off the OR table and be 100% pain-free. You know, I don't know. You may only have a 30% improvement in pain. You may only have a 10% improvement in symptoms and pain. Or you may have 99.99% complete resolution. And there's not I don't know. So there is always the possibility of having a surgery and having a good surgery and getting all of the endometriosis out and still not getting to that 100% pain relief or symptom relief. So, and that's the reality. That's the reality of it. No one can really, and I think if any surgeon tells you that, hey, if you have surgery with me, I can take care of it, you will get relief and you're going to be 100% pain-free. I think that would give me pause if a surgeon is saying that, because I don't think that anyone can say that for sure.
That's a perfect segue into our next point of just see if you can go to the next slide of just some red flags for finding the right specialist.
Okay, only offers ablation. And these are great questions to ask too. And if your surgeon gets defensive, if you ask these questions, then that's certainly a red flag. So if they say there's no difference between ablation and excision, I think that's a huge red flag. If again they're trying to put you on your 47th birth control formulation pill, or trying to just switch you over and over and over again to different things without even saying, hey, you might have endometriosis, and the way you diagnose and treat is with a laparoscopy, I think that's a red flag. Claims high success with basic laparoscopy, red flag. I mean, I can tell patients, look, I can get out the disease, but I cannot guarantee that this surgery is going to help. I think it will. I think it will change your life. I really do. But on the other hand, it doesn't matter what I think. It matters how you do after surgery. And sometimes, you know, I think endometriosis is really tricky. A lot of times endometriosis is the thing that started everything off. And I think, you know, there's pelvic floor physical therapy. There's other things that can help with symptoms and pain after surgery. But just with surgery alone, I think it's difficult to say you've been in pain for 20, 30 years, you know, decades, ever since you were 12. Have one surgery with me and you're going to be completely fine. I just think that's not true. And I think it offers, I think it's just, I would be concerned if someone said that to me. Limited experience with multi-organ involvement. So, you know, a lot of my patients that I do surgery on are, it's not their first surgery. It's usually repeat 2, 3, 4 surgeries, right? And it's because that, and I always ask for the operative report if I can get it from their previous surgeon. And it's interesting because a lot of times these operative reports they're not very helpful, but they'll say, you know, endometriosis noted on the bowel or endometriosis noted over the right ureter. But because, you know, it wasn't, because of risk of damage to the organ, you know, we will just put the patient on Orilissa or Lupron after surgery. And I think it's fine. First of all, if your surgeon doesn't feel comfortable removing endometriosis off the bowel, you really don't want them to remove endometriosis off the bowel. That is like, you certainly don't want that. So I don't ever blame the doctor for that, because you really don't want your surgeon doing anything that they do not feel comfortable with, right? But what I do have a problem with is, first of all, if they don't tell the patient that there's endometriosis on the bowel. And look, I couldn't do it, but go to so-and-so or so-and-so who can do it and who can remove it. You know, I think that would be a good next step. And then the other thing too is when they're like, oh, we'll just treat the rest of it with Orilissa, or we'll just treat the rest of it with Lupron. That's a huge red flag. But like I said, it's never okay. I think it's completely fine for a surgeon to be like, look, I don't feel comfortable removing it off the bowel. I mean, that's completely fine. No one's going to fault them for that. But they do need to be honest and tell you, look, it's on the bowel, and then also, and then, you know, if I would prefer that they refer to a specialist, but a lot of times they don't. Unwillingness to work with other specialists, yeah. So I think surgeons in general, we have big egos, right? We really think we're just like awesome and we're God, which I think you have to have a little bit of a God complex if you're going to cut into somebody, right? So you have to have that confidence, but you also have to know your limitations, and you also have to know that, look, it's not about me. This surgery is not about how awesome Dr. Liu is and that she can do all of these cool things. This is about what's doing the best thing for the patient. And while I was trained in urological colorectal stuff, because I did a really awesome fellowship at Mayo Clinic with gyn-oncs, and we did everything because it was the Mayo Clinic and we just did everything. And so I feel very comfortable with that. I never hesitate to ask for help. Like I said, I always have at least one other specialist in the room. First of all, for a couple of reasons, because I don't want to have to depend on a resident or a student or an intern to help me with these crazy cases. I just think that's just like, that's not a good thing, because like I said, you don't want a resident to help, or I don't want a resident to help me with these crazy cases. So I always have another specialist there. And then also, I think it's just good, you know, you have, let's say I have a colorectal, I have a urologist and me in the room. So that's 3 pairs of eyes looking at the patient, you know, and doing, like, all our focus is on the patient. I think 3 pairs of eyes is much better than my own eyes. And I think it's, like I said, I think it's just better for the patient to work collaboratively. And complication rates go way down. They go way down when you have multidisciplinary specialists in the room. And not only that, but I think it's, like I said, I think it's just better for the patient. It's safer. And while technically, yes, I can do all of it, I like to have friends in the OR. You know, what's wrong with that? What's wrong with working with other people? It's a team effort. And so if you find a surgeon who's like, I can do it all, they probably can. Maybe they can, maybe they can't. I don't know. But my preference, and I think it might even be because I'm a female and I have that kind of more of a collaborative, maybe I shouldn't say that. Never mind. Never mind. I'm not going to say that. Edit that part out, Nicole. I don't want to say that.
Gotcha.
Anyway, okay.
As of it, so now we'll just lead into our Q&A. We have a lot of questions here. So the first one, going back to the bowel and rectum, and endometriosis and IBS. If a colonoscopy cannot find it, can an MRI detect endometriosis on the bowel?
Sometimes. Yeah, sometimes. Sometimes. So I like to get MRIs on a lot of my patients, if not all of my patients. And because yes, sometimes it can see it. Actually, it's a better diagnostic imaging. It's a better diagnostic test to do for bowel endometriosis, in my opinion, than a colonoscopy, because it'll show you the wall. Not only will it show you the outside or the wall of the bowel, but it also can show you, oh my gosh, is it completely stuck to the back of the uterus? Or is it completely stuck to the cervix? Is it tethered to that right ovary? It will show you all of that because there's like 1,000, 1,500, 2,000 images, and you go through all of those and you can see all of the angles. Whereas, like I said, a colonoscopy, it's good. But you only see just the inside, right? And like I said, the bowel, the endometriosis on the bowel is from the outside in. So yes, I think an MRI is better.
And then just to follow up on that, when you're getting an MRI, especially to look for endo on the bowel, like when I had initially had my MRI, it was all clean, and then
Yeah,
when I had surgery, there was
yeah,
lesions just around the bowel and
yeah.
the colon rectum. So does it really, is that just because it didn't show up, or does it really truly matter who you, like which I don't know the word for it, but which radiologist is looking at, like if they know what to look for? Is it kind of clear cut, it's seen or it's not?
Yeah, no, I think it's both, honestly. A lot of times endometriosis on the bowel can be so tiny. It can be like 1 or 2 millimeters, if even. It's like the size of a pimple. So it's really hard to just, if you if you had maybe if you had a pimple and you went for an MRI, I don't think they'd be able to see that. I don't know, maybe they would if they're like a really good radiologist, but probably not. But on the other hand, if you have a radiologist who is really well trained in endometriosis, and we do work with some of them in the city, they're excellent. Um, they are able to really, a lot of times they are spot on. But again, if these lesions are so tiny and they're, like I said, like the size of a pimple, even the best MRI, even the best radiologist in the entire world would not be able to see that. And that's why it does require laparoscopy.
Gotcha. And then to talk, the next question is hip pain common, especially on one side with endometriosis?
Yeah, it is. I mean, it's not uncommon. I'm not going to say, yeah, it's common, but it's not uncommon. And especially when patients tell me that like it's on one side and they're like, yeah, my whole left side is fine. It's my right side. It's my right sciatica. It's my right hip. It's my, it goes down the top of my right leg. Yeah, that to me is very suspicious for endo, but it's not always, it's if you have pain on both sides, all my patients are like, no, it's equally bad on both sides. It still could be endo, but yeah, pain in the hip is completely. I think that's a clue that it could be endo.
And then the next question is from one of your patients, actually. How fast does endo come back after excision? Had surgery in January 2024, and in October 2024, and already has, oh, and in October 2024 already has 2 endometrial cysts, in over MRI.
Oh
Took
no, really?
so actually, Ludovica, if you want to ask your question.
Yeah, mute yourself. Unmute. I can't hear you.
I don't want to speak for you.
Okay, sorry, dealing with
Hi.
this. Hi. Yeah, the question is, I've
Mhm.
been dealing with the post um, post excision. So
Yeah.
post excision, I had endometriosis stage 4, so it was
Yeah, I remember
yeah,
you. I
of
remember you.
course.
Course. I remember your
But for
comments.
whoever is listening that maybe have a similar situation, it was in the rectum, in the bowel, and
Yeah.
had this cyst just in one of the ovary.
Yeah.
And the surgery went well. The recovery was okay. It's rough, but
It's rough. Yeah.
it takes longer than they say it takes, because it's a long surgery, and actually our bodies needs time to recover. But then basically it was hard to find someone that was a specialist covered by my health insurance. And that's where it took me so long to actually find someone that does excision at NYU and is covered by Health First. And I managed to finally meet her in October. And she was like, well, because I was always super bloated, she was like, well, let's do right away an MRI.
Mhm.
And because I also had an adenomyosis and other abnormalities, she was like, let's do another biopsy now just to make sure that there was not a development on that. That was good, but the MRI showed 2 small cysts, one in each ovary.
Oh man, I'm so sorry to hear that. Yeah.
So yeah, that was my question, because she was like, we if you have symptoms, we can start hormonal hormones, but you take it without getting a period.
Mm-hmm.
And since I started that, I became a little bit psycho, and but mostly I am even more bloated. I'm not in pain, but the belly is just like this, and I am stinky. Like it's like like, PMS symptoms, when you're like super bloated and you're a little gassy
Yeah.
and everything is wrong. So basically, but also I was bleeding every day. So I tried this hormone for like 5 months. I'm still like, sorry, he's beeping everything here. Stop beeping. Shh, shh, shh. I started, so I let my body have a period just last week because I was going crazy, and my
Yeah.
body was
Yeah,
basically
I needed to
asking me
bleed, right?
that. And once I got the period, I like belly went down, no more crazy gassiness.
Mm-hmm.
But now she put me on a new hormone,
Okay.
thinking that the estrogen was too high. Let's try this different one. But my question was like, so it's not uncommon for people with stage 4 that is already very spread to have a, like, that it comes back.
Yeah.
Is
Yeah.
there anything we can do? Because I am doing also pelvic therapy,
Good.
and that was actually, I recommend anybody here in the room or anybody that has someone with uterus and those things we have, go do pelvic therapy, because it's like it opens a new world. But yeah, other than those things, is there anything that we can do to prevent the development or?
Yeah, I mean the ovarian cysts, the endometriomas, those are tough. The literature says that recurrence rates with endometriosis is less than 30%. Obviously, you're not in that category, or you're
I
you're
am in
not,
the
yeah,
30%.
you had a recurrence, obviously. And I find that with my patients, and I don't know if it's just me, but it does seem, if you've had an endometrioma before, if your ovaries, I don't want to say grew an endometrioma, but if you had an endometrioma in the ovary, you're at higher risk of recurrence of your ovaries growing another endometrioma. When we do this surgery, like when I did your surgery, I took out the endometrioma, but it's not like I go around and I cut and I dig in the ovary looking for little tiny baby endometriomas. And so for endometriomas, I actually do, first of all, I have no problem with hormonal suppression as long as it doesn't cause symptoms. And I do like my patients to go on hormonal suppression after endometriomas, if they have endometriomas after surgery, because what hormonal suppression or birth control pills do is it prevents you from ovulating. So it just keeps the ovaries at a nice steady state. You don't create a new follicle every single month. You don't ovulate, and so it just kind of keeps things just nice and steady. And so I think for patients with endometriomas, that's good to keep the ovaries more or less quiet. Because otherwise there is a risk. I think at 2 years, I think it's like 30% will, if they're not on suppression, there's I think it's 29 or 30% will have a recurrence of endometriomas. So that being said, I mean, I don't know who your doctor is, honestly. I think that if you felt okay when you weren't on the birth control pills or the hormonal suppression, you could I mean, I don't know, especially if you were having such bad side effects, that's not good quality of life either.
Yeah.
And maybe those endometriomas, maybe they'll stay tiny, and it doesn't mean that you necessarily need to have another surgery if you're feeling okay. If you're not, then we should talk. But if you're feeling okay, and then you could potentially just kind of see how things go. But it's a tough situation. I'm really sorry.
Mm, thank you.
And then next question from Kathleen. Actually, Kathleen, if you want to unmute yourself, I don't want to speak for you either.
Hi, thanks for your time. I was just curious on your thoughts on I know you talked a little bit about norethindrone. Um, yeah, your thoughts on like norethindrone post-op first
Mhm.
excision surgery, and also kind of like when to know when to explore a second surgery. My excision surgeon doesn't think that um, my worsening right pain is related to endo because my
Okay.
endo was superficial. It was excised off my bladder, uterus, pelvic sidewall, rectum, and a little bit ablated on the ovaries. These
Mhm.
two tiny spots that she said would have been unsafe to excise. I don't know, but
Yeah. Yeah.
and then she said so it's unlikely to have gone elsewhere. But yeah, I feel like I'm drowning trying to find the like if the cause is endo for the worsening right-sided pain. And my recent MRI said that I had an IUD visualized, but my IUD had to be surgically removed post-op because it migrated. Um, so it had to be removed like 3 months after the surgery. And then, so that the radiologist said, she spoke with the radiologist and they said it's likely a dictation error,
Yeah, it
hopefully.
sounds like it's an error.
Because I was
Yeah.
like, but yeah,
A
I would
whoopsie.
appreciate any insight on norethindrone use specifically, like post-op, and just kind of yeah, any insight is. I really also just appreciate everything you've shared. This has been really helpful and
Oh, good.
insightful. Thank
Yeah.
you.
So norethindrone, I think it's completely fine. I mean, if you're tolerating it, I put my patients on norethindrone as well. If they want, yeah, I don't force anyone to go on post-op suppression. I really don't. I don't think it's, I wouldn't want anyone to force me to take a medication that I don't want to. But I think norethindrone, I do, if my patient's like, yeah, I'll go on suppression or let me try it. I love norethindrone. I think it's good. Some people can't tolerate it. Some people literally go crazy on it. And so we're like, okay, we shouldn't do that. But I think for patients who can tolerate it, I do think norethindrone's a nice choice. I have to ask you, did you have your appendix removed?
I did not. She actually, in a recent appointment, said that if we were to do a second surgery, which she's not against, she's just worried it could make things worse since the
Yeah,
pain has continued after the first surgery.
yeah.
But if I were to do a second surgery, she would opt to have a general surgeon in there just to remove the appendix
Yeah, the
because of,
appendix should, yeah.
yeah,
Yeah,
yeah.
we gotta eliminate all sources or all causes
Mm.
of right-sided pain. So I definitely think the appendix should go. I usually take it out on like 99% of my patients just because of that. The other thing too is I think if things are continuing to worsen, it really the decision is up to you. what you want to do next. If you were my patient, you came to me and you're like, look, and this is not getting better. My quality of life is impaired. I know it was superficial, but you know, maybe there's recurrence, and there certainly could be. I would say, okay, let's talk about this. Have you done pelvic floor physical therapy? Are you open to going to see some pelvic pain docs? Have you tried some other things other than just going straight to surgery, which we can always do. I tell my patients, look, I'm a surgeon. I love to operate. I will operate on you tomorrow if you say yes. But I also want to make sure that the surgery is going to help you and help your symptoms, because the last thing I want to do is just operate on a lot of people just because I like to operate. But it not help. I want you to come out of the surgery better than you did before. And a lot of times, it's unclear whether that's going to happen. No one knows if that's going to happen, but I always do try to keep you out of the OR as long as I can between surgeries, and try to get you more time while also giving you back quality of life. So a lot of times I'll tell my patients, are you open to trying pelvic floor physical therapy? Because some patients haven't tried it. And if they say yes, then great, let's do that. Are you open to maybe seeing, I work with I'm very lucky being in Manhattan, because there's some really, really, really good doctors here. I work with some really good pain management doctors who just only focus on pelvic pain. And they've been so good with my post-op patients who do have recurrent symptoms, who are not, we don't necessarily want to go to the OR right away. So, that's another option. Acupuncture can help. And unfortunately, this all costs a lot of money. It costs a lot of money. It costs a lot of time. And a lot of times that's just not feasible for patients. But I do try to delay return to OR if we can. On the other hand, I still tell my patients, look, if you're trying it and it's not working and your life is getting worse and worse and worse, and your quality of life is literally in the toilet because of these symptoms, and I'm happy to take another look. I'm happy to go in there, take out that appendix, take out any other endometriosis that I see that could be recurrent, or maybe I missed something. But at least we tried X, Y, and Z, because what happens if we come out of the second surgery and you're still in the same, you still have that right-sided pain? Well, then we're back to where we started. And then I would say, okay, well then now let's do pelvic, so I would rather do the conservative management first and try to get you quality of life without returning to the OR, if we can. But at the end of the day, you know your body better than anyone else. And if you're like Dr. Liu or Dr. So-and-so, I just want someone to take a look and see. And, I know it may not be endo, but there's something going on that I think there's something going on. And I think that's reasonable.
Thank you so much for sharing all your insight. It's super helpful, and I really appreciate you. Thank you.
You're welcome.
We are at time, Dr. Liu, but if you have a few more minutes to answer the rest of the questions, if
Yeah,
not.
yeah. Let's go. What time is it? Ooh, it's 7:59. We are.
Yeah.
Okay, Christina. I have stage 4 endo, had a removal of endometrioma over 5 years ago. I have IBS, but my pain isn't bad. 10 fibroids. Oh, wow. One on the inside is causing bleeding. Had one for 20 years and it's put on low estrogen. Last year it failed. I was put on Slin. It just stopped bleeding after to do a myomectomy from the inside because she thinks it's from the fibroid. But then she said it would maybe need 2 removals. Now I wonder if I actually need the myomectomy since I'm no longer bleeding. I got another opinion. It was recommended a hysterectomy, leaving my cervix and ovaries. I'm 43 years old, and I would really appreciate your opinion. Wow, that's a lot. You've been through a lot. So, I mean, there's so much more to you, Christina, than these like 6 paragraphs. But so it sounds like you have a couple things going on, right? You have fibroids and history of really heavy bleeding, as well as stage 4 with an endometrioma. And now it seems like your issue is that you were having a lot of bleeding, and it looks like there's a fibroid. You have a lot of fibroids, but there's one inside the cavity that's called a submucosal, submucosal fibroid, which means that it's inside the cavity, and that can cause a lot of bleeding. So yes, your gynecologist could do a myomectomy from the inside. That's called putting a camera inside the uterus. That's called a hysteroscopy, and removing that fibroid. So there's no incisions in the abdomen because it's done from below. And that could potentially help with the bleeding. But if it's a large fibroid, she's right. Sometimes it has to be what's called a stage procedure. So she may not be able to get that entire fibroid out in one surgery. She may have to bring you back, a few weeks later to complete it because it's not safe to do it all at once. I've had the same conversation with patients who have a large fibroid in their cavity. But now I'm wondering if I actually need the myomectomy since I'm no longer bleeding for 2 months. Maybe not. I think at this point it's about symptom management. And if you said you don't have a lot of pain, so that's great. That's perfect. And if you're really not symptomatic with the bleeding, and I don't know if you're still on Slind, but if the Slind is helping and you're living a good life and you're happy, then maybe you can just kind of wait. I don't think you have to rush to the OR. The other option or the other opinion is a hysterectomy. That would certainly take care of your bleeding for sure. I would remove your cervix though, especially since you have stage 4 endometriosis, because a lot of times there can be endometriosis into the cervix. So anyone who has suspected adenomyosis or stage 4 endometriosis, then they're going to have a hysterectomy. I personally will never leave the cervix behind because of the risk of having endometriosis on the cervix, and then that means I'd be leaving endometriosis behind. I can't tell you how many patients I've had to do surgeries on to take out their cervix after they've had a hysterectomy when their cervix was left behind, and then they still have pain, they still have bleeding, and then I have to go in and remove their cervix, and there's endometriosis all over the cervix. So for my patients, I do recommend, especially for someone who has a history of stage 4 endometriosis, removing that cervix. Keep the ovaries. You're very young. You don't need to go into premenopausal. You don't need to go into oh my gosh, I'm sundowning, Nicole. It's like past my bedtime, 8 o'clock, and I'm off the clock. No, so yes, leave the ovaries because you don't want to go into premature menopause. I got it out.
Dr. Liu, thank you so much. Can you hear me?
Yes, I can.
Wonderful. Thank you so much. I'm wondering if I do leave my ovaries, wouldn't my endometrioma come back again?
Not necessarily. I mean, yeah. So yes, yeah. No, if you have your ovaries still in, then your endometrioma could come back. You're absolutely right.
As long as I'm not on a hormone, right?
I'm sorry.
Like if I get put on a hormone, like if I continue taking the Slind, then it probably won't come back.
It would decrease the likelihood of it coming back. Yes, you're correct.
Okay. Okay. Thank you so much.
You're welcome. Caitlin, I think you're my patient. Can you explain why some patients experience ovulation pain and how excision surgery may help alleviate this? Can you explain the role of endometriosis and recurrent ruptured ovarian cysts that are not? So ovulation pain with endometriosis, a lot of times it doesn't have anything to do with the ovary. If you have endometriosis and it's making that ovary get stuck to the pelvic sidewall, so anytime you ovulate, that is going to cause a lot of pain. But on the other hand, some patients just have ovulation pain. They have ovulation pain even if they don't have endometriosis. So you could have, it's unclear as to what your specific situation is, but if you do have endometriosis and you have ovulation pain, it could be because there's endometriosis on the pelvic sidewall, and every time you ovulate, it creates it irritates those endometriosis implants, or the endometriosis implants irritates the ovary when it ovulates. Who knows what that relationship is like, but it's usually going to be because of the endometriosis. But like I said, some patients, even if they don't have endometriosis, some people in general just have ovulation pain and they don't have endometriosis. Can you explain the role of endometriosis in recurrent ruptured ovarian cysts that are not necessarily endometriomas? Is it hormonal related? I don't really know how to answer that question because I think some patients just whether or not you have endometriosis, you do create, every month you create a follicle, which is, basically a cyst. And when you ovulate, you rupture that follicle or that cyst. That's called ovulation. And that's certainly not an endometrioma. That's just normal physiology. The role of endometriosis in recurrent rupturing ovarian cysts. I don't know if endometriosis actually has anything to do with ruptures of cysts. I think that a lot of times patients with endometriosis will go to the ER because they're in so much pain, and you get an ultrasound and there might be some fluid in the cul-de-sac, and the ER doc is like, you just had a cyst that ruptured. And you're like, well, how do you know that? And they're like, well, because there's fluid in the cul-de-sac. But really, I don't think anyone has ever had proof. Or sometimes there is. Sometimes, and I'm not saying that people don't have ruptured ovarian cysts. I think that they certainly do, and it can cause a lot of pain, and it has nothing to do with endometriosis. But I think a lot of times, being diagnosed with a ruptured ovarian cyst sometimes is not. I think it's just what people say to make you go home from the ER. But yes, I think it is hormone related. What long-term effects have you seen people experience from Lupron, and were they experienced after 2 months use? Long-term effects, brain fog, hair falling out, persistent hot flashes. And 2 months is not long, thank goodness. But these side effects can happen immediately. And it's difficult to know who's going to have long-term side effects, or who, once they stop it, a lot of times it's like, okay, I feel better, but other times it can linger. So, but those are the biggest things with Lupron that I've seen. If I've never had endosurgery at 60 and now I suffer with autoimmune issues as well as stomach issues, is it worthwhile to have surgery at this point in my life? Haven't had a period since 42. I think surgery, that's I think that is a longer conversation to have, because it does sound like there could be some other things that could be going on that could be causing the stomach issues other than endo. Could it be endo? Absolutely. I've done endometriosis on enough postmenopausal women with endometriosis and symptomatic, even though they've been in menopause for years. But again, it's one of those things that you really have to have a conversation with your doctor about. But in terms of postmenopausal endometriosis, it's a thing. It's a thing, and it can cause symptoms. So whoever says, oh, you can't have endometriosis because you're in menopause, they don't know what they're talking about. How do you feel about progesterone supplementation for endo? Like progesterone, like progesterone only pill, like in terms of, I think it's fine, as norethindrone, Slind, those are the main ones that are used. The micronor mini pill, progesterone suppression, I think those are fine. I think that's completely fine. As long as it doesn't give you side effects, and as long as you find that there's benefit, totally fine. Have you ever seen or heard of anyone having endometriosis on their esophagus? I personally have not. I have not, and I don't know if I've talked to anyone who's seen endo on their esophagus, but I will definitely ask people, because that's pretty intense. Oh, you're so welcome. Oh, two-part question. How long is it safe to be on Depo for? I was diagnosed with endometriosis 10 years ago when they found endometrial tissue in my pathology appendix. That's not uncommon. A lot of patients will get diagnosed with endometriosis because it was found in their appendix, and the general surgeon is like, oh, it's not appendicitis, it's endometriosis. When I asked how could that be, my OBGYN told me that I have the kind of endometriosis that travels through the blood. Is that a real thing? I have endometrial cysts on both ovaries, and I am 45. So you literally have stage 4 endometriosis. The endometriosis that travels through the blood, I mean, there's so many different theories on how endometriosis spreads. Hematologically is one of those ways. That is a theory. I actually don't believe that. I think, oh my gosh, we don't have enough time to get into the theories of endometriosis and the origins of endometriosis, but I don't, is it a thing? Yeah, I guess it could be. No one really knows how endometriosis spreads or travels or that, but I don't think it's hematological spread. So I don't know if the OBGYN is necessarily a good source for that. Two-part question, how long is it safe to be on Depo for? I think it's 2 years. But you'll have to double check. For me, I'm a little embarrassed. I don't know, but I do believe it's 2 years. I don't do the depots for anyone. I just focus on surgery, but I think the Depo for Provera shot is 2 years. What else?
Thank you so much for answering. I'm sorry. I didn't want to like interrupt you, but I just want to say thank you. But that scares me because it's been 10 years that I've been on it. So, or actually,
Yeah.
it's been 8 years.
So
I've been,
are you getting a bone density scan?
I haven't been because my doctor told me that I shouldn't worry about anything. And of course it's an OBG. So I don't know. And this is all, I'm just honestly terrified. And just to hear you tell me I'm stage 4 is like, oh, but
Yeah, no, you have bilateral endometriomas and you had it in your appendix. I
yeah,
mean, it's like
and
you're the real deal. This is
and I
not.
don't, yeah, and I don't have it anywhere else. Like there's no chocolate cyst anywhere. They did I'm just I don't know. I just
How do you know
appreciate
you don't have chocolate cyst anywhere? You have it on your ovaries. That's chocolate cyst, right?
no, but I meant like anywhere else. That was it. There was those 2 confined places. They did the when they did the emergency surgery, so they said everything else was clean. There was nothing. And then
Who did the emergency surgery? A generalist, right? A general surgeon?
yeah, and it was his first time ever seeing that in the pathology. He was shocked.
So I don't know. Don't
I
believe.
don't trust anything
I
they
mean
say.
that's fine if they told you that, great for them. But I can 99.99999% tell you that it's not just limited to your ovaries and the appendix. I can tell you that right now.
Yeah, I had a feeling, but I just thank you for everything you're doing for
You're so
endometriosis.
welcome.
I
And
appreciate
don't quote me on the 2-year thing. Like I said, I honestly, I'm embarrassed,
No, it's okay.
I don't know for sure.
I had done the research and I thought it said 5 and it's been like closer to like
Okay.
8.5 for me. So that's why I was like, I mean, and I'm 45. So I'm like, do I
Yeah.
stop it? And I mean, I literally gave me my life back because I was bleeding constantly
Good.
and in pain. But
Yeah.
you mentioned lightning crotch the other day on one of your videos, and I'm like, oh my gosh, that's what it's called. That's what I have.
Yeah.
I'm
Yeah.
sorry. I don't want to take
Yeah. No. You definitely you definitely should talk with your OBGYN about the Depo, and then you can always consider coming off the Depo and seeing what happens, but you have stage 4 endometriosis.
Thank you.
I hope it's fine if I have, my appendix was not removed, but now it's causing me. Do you think another surgery could be recommended? Thank you so much. I mean, I think it's the conversation that I had with oh man, I forget, but about the persistent right-sided pain. I think it's one of those that's one of those things that you have to think about. Okay, well, we could do another surgery. Absolutely. It could be the appendix. Absolutely. But is there something else that you could try to do before running to the OR, before going for that second surgery, to see if it helps that right-sided pain? And if so, then great. Then you got yourself out of another surgery and your symptoms are better. But if not, then I think another surgery is reasonable. I don't think it's unreasonable, but I do think that it's always good to think about, well, what can I do to stay out of the OR longer and buy myself more time? Okay, are we done?
Yes, thank you so much, Dr. Lo. Thank you for staying on and answering everybody.
You're so welcome. You're so
then-
welcome.
Just for everybody else, this is just 2 QR codes. One to Dr. Lu's website, and one to Dr. Lu's Instagram as well. She posts so much information on Instagram. It's like a endometriosis guidebook. Really make sure you're following
It's
her.
a lot of cringe-worthy moments, but maybe there's some helpful information there.
Really is a lot of helpful information.
All right, guys. Well, thank you so much. And Nicole, let's do this again.
Yes,
Anytime.
sure. Thank you. I'll message you offline.
Awesome. All right. Good night. Have a good night, everyone.
Hey, everybody.